it's much more effective to give people information on what they should be consuming than to try and pull things away, to try and go through with them and find things they like and say, yeah, get a little more of that. Exercise is important, and trying to improve metabolic health through exercise is very much important. And I find that because the traditional American diet is so far divorced from what needs to be done to effectively control metabolic health and to optimize it.
So as a physician, or primary care physicians that are dealing with a lot of these patients that get diagnosed with type 2 diabetes, you said about they stay up to date, they have to keep up with the new advancements. Again, obviously, the pharma industry does a really good job of updating the physicians on the drugs and prescribing them and making revenue out of that. But outside of that, what do you suggest if someone someone listening in is a primary care doctor, or is about to go through residency, or is a younger physician? What is your advice to them to come up to speed with this, and at what priority level should they be able to do that?
The number one thing that they need to do, and this should be a very high priority for them, is to get educated on how to interpret research studies themselves. And the better residency programs do this with residents. The one I attended actually was very good at it. But I find a lot of physicians don't necessarily know how to interpret themselves. And that's a big problem, because a lot of the information you get from the pharma industry isn't really an accurate interpretation of these data. It tends to be presented in the most favorable light for their medication, and that can actually be misleading with regards to when certain things should be prescribed. And interestingly enough, because pharmaceutical companies are so hyper focused on their one drug, they also miss information that studies are put out where we're using combination regimens and how effective these can be. And so with regards to diabetes, there was a recent study I really feel the need to mention, and it was called the EDICT study. An MD researcher by the name of Ralph DeFranzo, who's been one of our foremost diabetes researchers in the United States over the past several decades, was the primary author on this paper. And EDICT was really significant because it took 3 older drugs and combined them and compared this to one of our most commonly prescribed progressions now, which is starting with metformin, adding a sulfonylurea, a medication that increases secretion of insulin from the pancreas. And then if that combination fails, taking off the sulfonylurea, moving to insulin. Well, it compared that regimen long-term with our first GLP-1 and least potent exenatide, which is an interesting story itself, because it was an accidental discovery when they were evaluating the Gila monster and its venom and saliva as a potential medicinal. And they accidentally discovered GLP-1s that way, which is, to me, absolutely fascinating. So exenatide, though, combined with pioglitazone, which has been on the market since the 90s, and metformin, which was introduced late 70s, early 80s in the United States. Those 3 medications combined over a 6 to 8 year period showed better glycemic control in very poorly controlled newly diagnosed diabetics than our traditional approach did. And when you dive into it, it makes sense, because the GLP-1, particularly in combination with these other 2 drugs, has the potential to improve insulin resistance, whereas our more traditional approach would tend to worsen it. And so the fact that we had better results with it is significant. But being able to take that data and run with it, especially if you start thinking about maybe substituting an SGLT2, which will have additional weight loss for
Mm.
one of those drugs, or for individuals who have very good insurance coverage, one of the new drugs like Ozempic and Mounjaro for exenatide, we could maybe even get much better results. So, yeah, as a physician, you need to be kind of keeping track of this research and reading it as it comes
Yeah.
out, because it really doesn't necessarily filter through in our recommendations from expert societies very quickly. That process takes a long time to shift,
Right. Right.
especially if we have an approach that's shown reasonably good results and we know it's safe. So we're just going to stick with that for a while. I would encourage, particularly new physicians, to get into the habit of just getting on the mailing list for, say, MedPage or Medscape. You'll get a lot of information coming at you, but look at the stuff that kind of jumps out at you and said, whoa, whoa, that's kind of interesting. Let's read
Yeah.
this.
Yeah.
And then you can get into the original research and see if the interpretation in the article agrees with what you can determine, and then start to figure out how that fits into clinical practice for you.
Got it. Got it. Now, a few minutes ago, you had mentioned about when one of your mentors, one of your professors, and five important things: diet, exercise, medication, right? And we've obviously talked a fair amount about diet and medication as well. Exercise is the middle. Do you, as a clinician, do you as a doctor believe that, let's say somebody has started the path of taking metformin, for example, or insulin, for example, since it's in this case, number 5 on the list of things that can impact your overall health and diabetes in specific, that if you did the first 4 things well, it is very possible, it is likely, again, patient dependent, not everybody is the same, not everybody's body responds the same, but within reason, within bounds, that the first 4 can actually help eliminate the need for the number 5th.
Well, that's absolutely true. And the earlier you intervene in the process, the more potential there is for what we would call lifestyle based remission of diabetes. That
Okay.
is a thing. And that is something, by the way, that most patients are not aware is a thing, at least when I was being exposed to them. And I don't think that that has changed too much. Maybe there might be a little more awareness now, but um, I don't think people are aware of how unextreme the necessary interventions are to achieve that.
Hmm.
And it really is about getting educated and being willing to make some serious changes in your life. But I always told patients, no matter what medication regimen I was putting them on for diabetes, and I wanted to be clear to them that there are lifestyle interventions that can be done that can either reduce or eliminate the need for these.
Yeah.
And whether we get there or not is up to you. And certainly, certainly if I find a newly diagnosed diabetic and I place them on a medication regimen and their A1C drops from 9 down to 4.8, which I have seen, then yes, a trial off medication is certainly reasonable. Um, One of the things you do have to be conscious of when you do that, though, is if we're using SGLT2s or GLP-1s and they induce a fairly profound amount of weight loss,
Yeah.
patients have to be prepared to make further lifestyle adjustments when they come off the medications to ensure that they don't just increase their caloric intake again and slide back up the scale.
Yeah, and it's interesting you say that, because what we have seen in the folks that we've had a chance to work with is that we did get members that were using the GLP-1 drug, especially the ones for that have an accelerated weight loss associated with that. And once they started making the modification of their lifestyle, we're using, for example, what we put together for them, they use this sort of as an off ramp to those drugs to
Right.
say, hey, I do want to get off of those at some point, because it's not a lifelong situation. And again, there are patients, there are consumers that do need the GLP-1 drugs for an extended period of time,
Mhm.
and I think they should absolutely consider, absolutely get those, because those are medically necessary, right? They are clinically necessary to give them the right health. But for the most part, a lot of patients can use lifestyle modifications, as you said, as an off ramp to say, hey, now that my A1C, for example, is in control or is starting to come down, and I know that lifestyle changes are working as well, can I start calibrating it down a little bit
Yeah.
from the GLP-1 and bring it down to a point where it's either negligible or completely gone? And that is, I think, the ideal outcome for someone on that, because they're like, I'm done with this drug. I don't have to worry about the side effects. I don't have to worry about anything else. But I've got the similar results from a control perspective on my diabetes, I guess, for that matter.
Right. Well, and medications, in my mind, always should have been viewed and always should be viewed as a tool. They are a
Mm,
tool in the toolbox. They are not a necessary intervention by any means, but they're a very effective tool.
mm,
And as I said, if an individual is willing and able to modify their dietary habits as they come off the drug, recognizing that appetite is going to increase
yeah.
as you come off. So, guess what? You're going to have to be aware of that and really be monitoring to make sure that your eating habits that got you to the point where we can take you off the drug stay in place so that we can keep you off the drug.
Yeah. Yeah. And so a segue to staying on the drug topic, if you will. I've seen stats that are just mind-boggling when it comes to insurance coverage, costs of these drugs that are effective. In some cases, for example, the cost of a GLP-1 drug in the U.S., the branded ones, can run upwards of $1,000 per month for a
Yep.
patient. And you go to countries like, for example, in Europe, you go to UK, you go to France, you go to Germany. We're talking about those drugs being at a fraction of the cost. In some cases, as low as $100 a month, right?
Mhm.
So in your mind, obviously, just outside of the obvious shit's expensive sort of a mindset, how do you think that the insurance coverage and high out of pocket costs of these drugs, how do they complicate things given the social and demographic makeup of the folks within the US that are diabetics, for example?
Well, I'm going to take it one step further because that number I quoted earlier, the 412.9 billion,
Mm,
less than 100 billion of that is medications.
wow.
And that does shock a lot of people. The biggest cost are the hospital-based interventions for complications of diabetes. It's poor control that is the primary cost driver. And whether you're talking about cost of dialysis, whether you're talking about cost of amputation surgeries, whether you're talking about cost of treating heart attacks and strokes that result from diabetes as the primary risk factor, those are your prime drivers of cost. One hospitalization for an MI that involves a cardiac stent placement will cost more than a lifetime of a GLP-1 drug.
Wow.
So that is something very effective to keep in mind if we're talking about cost. But again, it's really difficult to get the kind of medication compliance you need to just treat this disease with medications, right? You need somebody who's invested in really trying to promote their own health.
Mm,
One of the things I loved about osteopathic medicine that when I first found out about it pulled me to go the DO direction instead of MD was the original osteopath, Andrew Taylor Still, said the job of the osteopath is not to treat the disease of a patient. The job of the osteopath is to help them find the health within themselves and bring it forth. I loved that philosophy, and I still do to this day. And I think that's what we're talking about here is physicians, practitioners partnering with their patients to give them the tools they need to get to the healthy state themselves, to bring that health forth from within them.
man, that is powerful. I mean, as you were saying that, and I was trying to absorb it. Um, I mean, I think that could be and should be a mantra for all clinicians, nurse
I,
practitioners, PAs, physicians alike, because I I mean, I know there's a Hippocratic oath of do no harm, but we can extend it a little bit further to say, hey, let's not just use exclusion as an oath. Let's use it one step further and say everybody has it within them to be healthy. Nobody wants to be sick or die a miserable death. Nobody wants to do that. But and physicians, they are doing, for lack of a better term, not to get too religious, but they're doing holy work because they are impacting human beings' lives on a daily basis, right? So that responsibility, with great power comes, great responsibility, sort of thing, right? That mindset. So I love that. Can you repeat that quote real quick? I wanna hear that
Yeah.
again.
So Andrew Taylor Still, and this was said, by the way, in 1893. So it wasn't a couple weeks ago. But as he was opening the first College of Osteopathic Medicine, part of his initial address to his second class of students was that the job of the osteopathic physician is not to treat disease. And he actually said any fool can do that. He said the job of the osteopathic physician is to help their patients find the health within themselves and bring it forth.
Wow, I'm gonna remember that, and I'm gonna share that with not only obviously our viewers and audience are going to be able to hear that directly from you, but in other medium as well.